Hello, everybody, and thank you for joining us today. We welcome you to our webinar on long-term care diagnostic testing and stewardship for infection management. My name is Molly Bellis, and I'm a clinical laboratory technician at Absolute Genomics. Our goal today is to provide information for healthcare providers providing long-term patient care, academic researchers, and the general public who wish to educate themselves on important matters of healthcare. We have with us today several speakers with extensive experience in infectious disease management. They are Howard Wegman, President of Absolute Genomics, Dr. Umar Rahil, Director of Operations, Dr. Abbas Vaza, our Technical Supervisor, and Rachel Menina, General Supervisor. Our webinar will consist of a 30-minute presentation followed by a 5 to 10-minute Q&A session. We encourage questions to be entered in the chat during or after the presentation. We also ask that you please include your name and which of the speakers your question is directed towards. We hope this is informative and educational for everyone attending. I'll now give the floor to our first speaker, Dr. Umar.
Thank you, Molly. Thank you everyone else for joining. This webinar is aimed for nursing home and long-term care facilities to educate them on infection control and managing the cost associated with managing infections and the management burden that comes with the infection. So I'm really happy to present this webinar, and thank you everyone for joining us. So before I start, let me give you a brief overview of our lab. Absolute Genomics is located in Mayfield, Pennsylvania. Our corporate headquarters is in St. Louis. We are a CLIA CAP certified lab. And in this short span of 2 years, we are able to get 300 clients on board. And we really take pride in our QA/QC program. And because of this program, we were able to get zero deficiency in our CAP inspection. So let's move over to webinar. There are some major challenges that are coming towards long-term care facilities, and I'm going to touch a few of them. Due to improvement in healthcare system, more vaccines and drugs are coming. There are more therapies for cancer and neurodegenerative disorders. So people are living longer. So more and more people are coming to long-term care facilities, and that is kind of the future. In future we will see more people joining this industry. So like with baby boomers joining this kind of transition from in the next decade from middle age to aging population, there will be 77 million more people that would need long-term care facility. And another thing is the estimated stay is usually around 2 years, so 22 months. So that's a long time. So imagine the economic burden and infectious disease related cost associated with that. Usually the cost associated with living in these facilities is $500,000 for 5 years. So that's roughly $100,000 every year. So you can kind of realize the magnitude of this problem and how we can help reduce this cost. So now coming more closer, what you guys see every day in nursing homes in terms of challenges, So especially in infectious diseases, we see that there are 1 to 3 million serious infections every year. Those infections can be respiratory illness, urinary tract infection, wound infection. So there are a bunch of serious infections every year. So the most common infections that we see in nursing homes are respiratory infections, urinary tract infections, diarrheal disease, antibiotic resistant infections, mostly staph related infections. And if we look at the infections, the most common is urinary tract infection. As we know, as aging population need help with urination, they use catheters and other devices, and that can contribute towards urinary tract infection. So they're very common in these nursing homes. Uh, Another issue is, by 2065, the people with physical or cognitive disabilities will grow up to 150% that would require any long-term care or these things. So, this industry will be getting an influx, a huge influx. And with that, what is coming up, that aging population is usually immunocompromised. Either they got a transplant or they are going for some therapies that kind of suppresses their immune system, and which allows the bacterial and fungal and viral infections to take hold. So a common infection for a young person would not be as serious for someone who is aging, and that's because of their immune system being suppressed. Um, Another issue that is huge also in nursing care, nursing homes and long-term care facilities is the persistent infection. So, people with diabetes can have diabetic foot ulcers, or people with bed sores can develop those wounds or infections that are hard to heal, hard to treat, and they are due to antibiotic resistant infections. So that kind of takes us to the next step. So in this webinar, Dr. Abbas and Rachel will cover the antibiotic stewardship, how important it is to have the right antibiotic for the right infection. And that can really be a game changer. Instead of treating someone over the period of 2 to 3 months, you are treating someone within a week. So that contributes a lot in cutting the cost and management for that infection. So how can we help your facilities with infections, persistent and hard to treat infections? So at Absolute Genomics, we have designed cutting edge molecular tests that cover almost all aspects of nursing home and long-term care infections. So we have the respiratory panel, we have the nail panel, we have the wound panel, we have urinary tract infection panel. Of course, all of these panels come with antibiotic resistance stewardship program. So anytime there is a bacterial hit, we will run the antibiotic resistance panel and we will provide you the exact antibiotic that would work. It can be a broad spectrum, or it can be just antibiotic against a single pathogen. Finally, we also offer PGX testing because a lot of residents are on multiple drugs. They can be on psych and cardiac medications. So we want to help them and with drug-drug interaction and gene-drug interaction to provide them better drugs. So it's not trial and error and they are getting the best drug. With this, I will pass the presentation along to Dr. Abbas to go over these solutions and explain how can we help you guys with cutting the cost and infection in the nursing home. Thank you so much.
Thank you, Omar. So can you all see the ABX
Yes.
slide, right? Okay, so let's start with the critical issue of antibiotic resistance. As like some of you might be familiar in your long-term care settings or nursing homes, this is a big problem. And so let me start by giving a background. So antibiotics, as some of you might know, are antibacterial drugs that are prescribed most commonly in long-term care setting. And they have saved millions and millions of lives since their first discovery back in 1920s. Unfortunately, if you look at the data out there, up to 75% of individuals in a long-term care or a nursing home, they are inappropriately prescribed these medications. Now, that could be a problem. First, it could delay treatment of those individuals because the wrong antibiotic is provided. And it can enhance the rate of antimicrobial resistance mechanisms in bacteria. Now that not only can make additional resistant strains, as we see is in this example, like E. coli or K. nemo or Neisseria gonorrhea, which were previously treatable by affordable first-class generation antibiotics, but now they require expensive cocktails of multiple antibiotics to be treated. And it can be a substantial, it can have a substantial impact on the healthcare system. So as we know in US, there are more than 2.8 million infections due to antimicrobial resistance every year, and they can lead to death. So that's why there's a need that all these prescriptions are provided, appropriately. And this is compounded by the fact, if you look at in the past 100 years, we have limited supply of these antibiotics. So all these 6 classes that I mentioned here, we don't have several thousand. So, and especially in the last 30 years, we haven't made progress into new antibiotics discovery. So we are running out of them, and thus there's an important need that the prescriptions of these antibiotics is done in a proper manner. This is known as antibiotic stewardship, which is knowing which infection or pathogen is infecting the patient, and then prescribing the antibiotic that will work best for the patient. So at Absolute Genomics, we are proud to offer such kind of antibiotic stewardship. And this is known as the ABX Advantage panel that we offer. So what we do is we run for 11 antibacterial resistance markers in this test. This allows to test for 6 different antibiotic classes and provides an antibiotic that works the best for the patient. And because this is based on RT-PCR technology, it is highly sensitive and specific. This also removes the guessing game that normally goes in antibiotic prescriptions in a long-term care or a nursing home. And some of you might be wondering, how quickly I can get the results. Say one of my patients who needs the antibiotic has a very serious infection. So this is because it is PCR based, it's extremely quick. So within 24 to 48 hours, the patient can not only find out what pathogen they have, but also what antibiotic they should be using. And so moving on to say, now I want to cover what are some of the most common infections that happen in a long-term care. And then I will go over some unique challenges that each infectious disease brings and what solutions we can provide. Okay, so moving on, if we look at the data for long-term care or nursing home, the most common infection is either a respiratory infection or a urinary infection. So let's start with the respiratory infections. We all know they are extremely common, such as common cold, flu, influenza, or tonsillitis like strep throat. Or if you look at, say, severe cases of respiratory infections like bronchitis or pneumonia, they're also very common. They are a substantial cause of mortality. And if you look at the prescriptions that these infectious disease occupy, they are the #1 cause of antibiotic prescriptions. And thus, as you can see, more than half of these individuals are inappropriately prescribed these antibiotics. So that is a big problem. And as you can see, this is such a big number. Like every year, so many million people go to the ER just to get treatment for these respiratory infections. And so that is a big problem. Another issue with respiratory infections is there are several pathogens. So if you look at the bottom slide here, the ones that are responsible for each disease are highlighted here. And if you just add up this number, that's more than 20 pathogens. So we needed to have, in order to identify these pathogens, we needed to have another advanced technique that can cover all these pathogens in a single test. So we are using the OpenArray platform, which is another RT-PCR based technique, but much advanced. And it allows us to actually test 31 pathogens in a single swab. So this, as you can see here, this is how the panel looks like. It has several strains of aerobic bacteria, anaerobic bacteria, several viruses. And the ones that are most commonly found in respiratory infections are the ones that we have highlighted here. So we are covering all of them, including several others, which even though are rare, but could be important in this infectious disease. And again, all of this is done in a quick turnaround time. So within 24 to 48 hours, we have the report ready, available, and the patient can be prescribed. If there is any antibiotic needed, they will be prescribed an antibiotic. If not, they can have alternate treatments. So let me show you how the report looks like. So on the left is our typical respiratory insight report, where we test all the infectious pathogens here. So as you can see here, this is the summary of the report, where you can see in this case, the patient had 2 bacterial pathogens. And then this patient also had an antibacterial gene called MEC-A. And if you look at our antimicrobial resistance report, that provides information on what this resistance is. So this is methicillin antibiotic resistance. And based on the patient's allergies, all the history, this drug is prescribed for this patient. So amoxicillin will work best. And this is the dosage that it is recommended for this patient. So it's a very comprehensive picture that the physician can get. And so the treatment can be more personalized for that patient. Okay, so moving on to another respiratory disease, which I'm sure everyone is familiar, that's the COVID-19. And The reason I wanted to discuss this was this has created like a huge impact in our healthcare, especially economically, shutting down all these economies in the world, and also bringing new social challenges. And part of the reason is because the virus nCoV-2 is highly infectious. And so controlling an infectious disease, say in a long-term care, is a very big challenge. And especially if you look at the data for COVID-19 mortality, we see the highest mortality in this greater than 60 years age group, which we know predominantly makes up the population in a long-term care and a nursing home. And it's just unfortunate. 30% of all COVID-19 deaths happened in a long-term care. And so this is definitely a big, big problem. Another issue with COVID-19 disease is many of the patients experience no symptoms. So if you look at this, these are the classical symptoms of COVID-19. More than half of the individuals, 50%, won't even exhibit these. So how do we identify them? That is a challenge. And this is again compounded by the fact, I'm sure everyone knows, that we have all these different variants of nCoV-2 virus. And so alpha, beta, gamma, and now currently we have delta, omicron, or omicron variants. So all of these bring in unique challenges, like they have different infectiousness, they have different, they vary in their mortality, so how severe disease they can exhibit. They also vary in terms of can they be detected by a rapid test or not? So antigen-based testing can also be affected. So we needed to have an approach that can override all these variants and detect, patients who have the virus earlier. And so the technique that we have is based on RT-PCR, which is a molecular detection of nCoV-2. And what it does is it's requiring a region of ORF1A on the virus, which is unaffected by these mutations that normally we see in these variants. So we can ensure that the patient, as long as they have the virus, we can detect it. And because the limit of detection for these tests is so tiny, we can pick up any positive patient much earlier, even before they exhibit the symptoms. Okay. And once again, they have extremely quick turnaround time. So within 3 to 8 hours, say if a long-term care facility can find out how many people have this virus, they can isolate them much earlier. So that is a big leap in how to control infections in a long-term care or a nursing home. Okay, moving on to the second most common disease, the urinary tract infection, or UTI. So just to give a perspective, every 1 in 5 resident in a long-term care or nursing home gets a UTI every year. So that's a big number. And if you can see here, they also require urgent care because several of them end up in the hospital getting treatment. And most commonly, we see UTI infections in women. So there are 4 times more women than men who get UTI. But if you look at older age population, men also have like quite considerable amount of UTI infections. And we also see loss of antibiotic resistance in UTI infections. So especially like the most common hit, E. coli, we know that it has several antibiotic resistant strains that infect UTI patients. Okay, in terms of the symptoms of UTI, I've listed some of them here, but they could be variable. And unless these are treated in time, there could be issues like complications, which are listed here, and then that can become life-threatening. So it is important UTI cases are treated in a timely manner, and if there is any antibiotic resistance, such as due to E. coli, the appropriate antibiotic is provided. So most commonly we see E. coli, responsible for UTI, but then there are several others as are listed here. I also listed some of the fungi strains, which we know are important in UTI infection. Okay, so how does our panel look like for UTI infectious disease testing? So we can detect in a single urine sample or a swab 20 pathogens. And the pathogens that I was mentioning were commonly associated, the ones that are in red, we can test all of them, plus we are testing several others. So it's a very comprehensive panel. And again, this is based on our RT-PCR, so highly accurate, very sensitive. And within 24 to 48 hours, not only we provide the information on the antibiotic that the patient can take, but also get the result much earlier. Okay, so this panel that I'm going to talk about sexual and reproductive health. So this was a little surprising for me. Like when I looked at the data for long-term care, normally we don't associate STI infections with, say, older populations. But if you look at some of the latest studies on, surveys that have been done across, all these facilities, more than 50% of individuals above 65, they are sexually active. So they are prone to getting STD diseases. And even if you look at, the latest numbers for 3 of the most common STD diseases, chlamydia, syphilis, and gonorrhea, their numbers have gone like more than 50%, some of them like 90%. So that is a big jump. And there's a need, like especially in a long-term care facility or a nursing home, that proper management of STI diseases is also done. So if the STI infections are not treated properly, because several of them can develop with antibiotic resistant, say, strains such as Neisseria gonorrhea, then they can lead to complications. And these are some of the ones that I listed. And there are several signs and symptoms that one can see for an STI infections, and they vary depending on whether it's in men and women. So how do we test it? So we are offering 2 kinds of panels. One which is more targeted towards STI pathogens. So this tests for 13 pathogens in a single, either a urine swab or in just a vaginal swab or a penile swab. And we can test all the most common pathogens shown here in red, as well as several others. And again, this is provided with a antibiotic resistance report if there's any bacterial hit, and that is the STI pathogen panel. The second panel is much more advanced. It is much more comprehensive. We call this women's health, and this tests actually 24 pathogens in a single test. And most of the pathogens here that are added that are not in the STI, they are more focused towards women. So women, as you know, have some unique, physiology. They have some unique pathogens that can infect that physiology. So we have included the list of those organisms here. So by doing this, we can provide treatment for, not just for men, but also for women, depending on which pathogens infect each sex. Okay, and again, this is also done within 24 to 48 hours. So very quick. All right, now I wanted to revisit what makes up long-term care. So we know the population is aged. We know the population has comorbidities such as diabetes, or they are undergoing any therapies. Immunocompromised individuals are there. So there are many things that are found in those populations. What disease they are more susceptible to getting when they have all these complications? So wound infection is another disease that we see commonly in long-term care, especially like, in diabetics, immunocompromised patients. And if you look at, how severe they can get, actually wound infections, they are prone to, turning into chronic wounds. So they need like long-term treatments. And sometimes they can become, septic if they are not treated, leading to, for example, amputations. So it's a serious disease unless treated properly. If you look at some of the bacteria that are most commonly found in wound infection, it's Staph aureus. And in fact, we know that methicillin-resistant Staph aureus is quite common. So they also have antibiotic resistance. And these are some of the risk factors that I was mentioning. So old age, surgery patients, dialysis, transfusion patients, or immunocompromised, or diabetics. Okay, so how can we provide a solution for wound infection management? We are offering this wound insight panel, which can test for all the most common wound infections, such as Staph aureus with MRSA, or the others one like Pseudomonas, which we also see quite common in urinary infections as well, but also in wound. And we can provide a comprehensive report with 17 pathogens in this panel. So it's very quick and providing a drug that works the best if there's any bacterial hit. All right. Lastly, I'm going to go over another category of infections, which even though are not life-threatening, but we see very commonly in long-term care and nursing home. These are the nail infections. especially onychomycosis, which is a fungal nail infection. And if you look at the prevalence of these infections in, say, old age population, it's like almost 30%. So that's very, very common. Treatment itself for these infections require, expensive antifungals, and they all add up to quite a big number. Same goes for long-term care costs for treating fungal infections. If you look at the most common pathogen, that's the trichophyton species. So trichophyton rubrum, we see quite often. And what are some of the signs and symptoms of a nail infection? So the nail can have a thicker, it can become thick, it can break off easily, it can have a characteristic odor and thickness, as I mentioned. And the treatment is easy. It's just they have to be diagnosed earlier in order to avoid any further complications. And the risk factors are similar to the wound infections. So I have listed here. So how do we provide a solution for this? So we have a nail insight panel that covers for 17 pathogens. Majority of them, as I was mentioning, are fungi-based nail infections. So we are providing a very comprehensive list of fungi. The ones shown in red are the ones we commonly see are associated, but then we are also testing for several bacteria that could be important. And again, all of this is done in a timely manner, even though nail processing is quite complex, as shown here, but still we are able to provide results very quickly. So imagine a nail infection, if it needs to be treated, one can get the information within 24 to 48 hours, which pathogen it is and what treatment to use. All right, so with this, I'm going to hand over the podium to our General Supervisor, Rachel Manina. She's going to go over another important panel, which is the PGX panel that talks about how important it is to know about the genetics of the patient before prescribing the medication, because that could have some serious consequences. So Rachel, take it away. Rachel, I think your mic is mute.
Thank you so much, Abbas. Hello, everyone. So yes, I am going to give a little background first on pharmacogenomics, also known as PGX, before going into some of the solutions we offer for better patient management. So PGX is a form of testing that focuses on the patient's physiological response to medications based on their genetics. So oftentimes patients are given a medication that either does not work properly or has an adverse effect or possibly interacts with another medication in a way that may be harmful. And older individuals are actually quite susceptible to adverse drug reactions. Usually medications undergo 3 to 4 phases of clinical trials, and the sample size is supposed to be representative of the country, involving healthy volunteers and individuals who the medication is targeted towards. And this comes out to around 5,000 to 10,000 people towards the end of it, and we have 329.5 million people in this country. And unfortunately, as we can see, 10,000 is not very representative of the entire population. However, once that medication is approved by the FDA, we have the opportunity to see how vastly it affects different people. And so the FDA actually recommends PGX testing, and they do offer pharmacogenomics-based information on their website for over 200 different drugs, most of which are oncology-based. But the overall goal of PGX testing is personalized medicine. Everyone's body is going to metabolize medications differently based on their genes. And this test skips the line. It lets clinicians know from the beginning what medications their patients should avoid, and what they can take and expect a normal response from. We want to make sure that patients are getting proper treatment specifically for them. So at Absolute Genomics, we offer 4 different panels to accommodate specific patient needs. And so it is recommended that older patients test for the PGX Complete, which tests for 61 genes and generates a comprehensive report targeting all types of medications and other areas aside from the 3 smaller panels listed here. However, we do offer these 3 smaller target-based panels that focus specifically on cardiology, psychiatry, or pain, because not everyone may necessarily need a complete comprehensive report. So what are the main benefits of PGX testing? Well, first, PGX testing can offer better patient management by eliminating unnecessary treatments while streamlining others. For example, older patients are often treated with multiple medications, and it can be quite a journey to find a group of drugs that will work together with as few adverse side effects as possible. I'm sure most of the attendees know firsthand the challenges their patients face when trying out new medications. But with PGX testing, clinicians can cut out the guesswork and they can get that patient treated quicker in a more personalized manner. In addition, our PGX panel is the only test that we run with next generation sequencing instead of PCR. And next generation sequencing is a fascinating technology that allows us to test for multiple genes, whether it's whole genome sequencing or targeted sequencing, and it ultimately provides a more comprehensive data report on the mutations present in that patient, which can aid clinicians in accommodating more appropriate therapies. This is particularly helpful for PGX testing because it is more cost and time efficient than traditional PCR methods. So what are some of the solutions that we can offer to nursing homes and long-term care facilities? Well, to start, our turnaround times are excellent, usually same-day results, if not the following day, meaning the patient can get access to treatment sooner rather than later. It is actually extremely important that patients with infections are able to be treated quickly, since elderly individuals tend to have a slowed immune response towards infections. We also mentioned earlier that we offer antimicrobial resistance testing, along with any panel with a positive bacterial hit. If any antibiotic-resistant genes are detected, a detailed report is generated, and it focuses on the most ideal mode of treatment. And this ensures that the patient is going to get the right medication to battle the infection as soon as possible. As I'm sure you know, patients reside in these facilities for quite some time, and the infection can spread quite easily. So our workflow is designed to save the facilities and patients money by decreasing their needs for extended care by testing for multiple targets at once, whether they are bacterial, viral, or fungal, depending on the panel, and by diagnosing the pathogen as soon as possible, followed by antibiotic-resistant testing for bacterial targets. Facilities are avoiding the spread of antimicrobial-resistant pathogens, further avoiding the need for additional treatments and prolonged care. So, and I'm sure a good portion of those attending this webinar today are likely still using traditional culturing methods to detect pathogens in their patients. Now, there are quite a few issues with this method, starting out with timing. It can take on average 3 to 5 days for a culture result, and even then, only a few pathogens may be tested. Not to mention, detecting pathogens through culture requires individuals trained to look for said pathogens, as well as different growth needs based on the type of pathogen. So for example, a bacteria may need 3 to 5 days, a virus over 5 days, and a fungus up to 21 days. There's also an increase in risk of contamination spreading with culturing. And unfortunately, this leaves your patients very uncomfortable and waiting on treatment, which may lead clinicians to treat the infections with an antibiotic that may not work at all. And if that patient is already being treated by antibiotics, the results of the culture can actually be compromised. So all of this on top of an average of around 60% accuracy of pathogen detection is not ideal for patients battling an infection. However, with PCR testing, we can detect many more pathogens at once using assays specific to those pathogens while avoiding issues like contamination and the need for extensive time for the pathogen to grow. PCR is also 99% accurate in detecting pathogens in a specimen, and it only takes about an hour and a half once it's placed in the instrument. The data provided by the run is also very easy to analyze. It's straightforward. The patient is either positive or negative based on amplification. And following result analysis, clinics are going to receive a full detailed report on the pathogens present along with the antibiotic resistant report, all within 24 to 48 hours. So the patient is able to be treated right away with the right medication for the infection. This will combat adverse side effects and decrease the need to try multiple antibiotics until the infection is taken care of. Now, I know that we have mentioned quite a few times during this presentation about antimicrobial resistance and how we offer this form of testing. But how did this testing become so prevalent? Well, to start, we have seen antibiotic resistance since the first antibiotic treatments emerged. Since then, it has created quite a few obstacles for the healthcare industry to overcome. Therefore, it is our goal as a whole to combat resistance, since we can see how much it can prolong treatment, if not lead to fatalities in older patients. As we can see here on this infographic from the CDC, there are 3 main goals for prescription improvement. So number 1 is optimizing antibiotic selection, aka having the right medication for the job. Number 2 is reassessing antibiotic treatments when the results of diagnostic testing are available, such as antimicrobial resistance testing. And number 3, using the shortest effective duration of therapy. We know that the longer it takes for the patient to receive treatment, the longer they are living in discomfort, and the infection can spread and worsen. Many hospitals and clinicians rely on the research of science surrounding infectious pathogens and the ongoing resistance buildup to prescribe proper medications. Antibiotic resistance stewardship programs contain a team of scientists, researchers, data analysts, and doctors who work together to develop a thorough report that can assist physicians in prescribing proper medications. So, during this presentation, we have gone over the multiple challenges that nursing homes and assisted living facilities face on a daily basis. And based on these challenges, we would really love to help these facilities cut down on infection spread, along with the cost of management and treatment. Thank you all so much for listening. Now we are going to transition back over to Molly for questions and closing statements. Thank you.
Thank you, Rachel. So I'll start off with our questions here. Our first question is one of our attendees today would like us to further go into detail on antimicrobial susceptibility testing in a clinical lab setting.
What's the question? They just want to go over? I didn't get that.
Yes, she would love to hear the speakers address the topic of antimicrobial susceptibility testing in a clinical lab setting.
Yeah, so we have seen quite a lot of antimicrobial resistance, like in our patient samples, like all these clinical samples we test for. The most common we see is like the methicillin antibiotic resistance, but also like, beta lactamases we also see quite often, and sometimes the vancomycin resistance. So yeah, depending on, say, which disease it is, you see different kinds of antibiotic resistances. And that's a big problem because if we go back, say, 30, 40 years ago, this was not very common. But now, majority of these samples that are coming, especially from older populations where there's more chance for the immune system not to control the infection, antibiotic resistance can pop up.
Thank you. Our next question is in regards to the respiratory panel. What are some of the advantages of our Insight respiratory panel over other commercial panels on the market?
Rachel, you want to take that?
Sure. So our respiratory panel offers 31 targets. It's way more extensive. A lot of other competitors we have noticed the most comprehensive it gets to maybe around 10 targets, and they just will choose the most common. But sometimes you don't have a common infection, and that's why it's so extensive. We want to make sure that we can cover all the bases.
Thank you, Rachel. Our next question is in regards to urinary samples and how are they stabilized? What is their expiry date and why?
So the expiry date for a urine sample is 3 days. And in terms of stabilizing, so we use like a proprietary urine sample collection kit that has a matrix that stabilizes the urine sample. So for 3 days, we can ensure that the sample is stable.
Thank you. And we have another question. How do we get antibiotic profile by PCR?
So that is a technical question. So let me go back. So what we are testing in an antimicrobial, resistance panel is genes that could make the bacteria susceptible. Okay. We are not directly testing the antibiotic profile by culturing the bacteria and then putting the antibiotic and seeing are they resistant or susceptible. That could be done, but that will take quite some time finding out what resistance is there. And the beauty of this, RT-PCR based testing is we are providing results much earlier. So say, even if the bacteria has the gene, there is a potential, there is a resistance there. Okay, we are not directly showing it by culturing, but at least there is a potential. So it's better not to take that antibiotic. As long as there is a resistance, better take another antibiotic that doesn't have the resistant gene. I hope that answered the question.
And this question is for Rachel in regards to PGX testing, and how is this test administered?
So what we would do is you would take a cheek sample, and that is brought to the lab, it's extracted, and once the DNA is purified, it can go through something called library preparation, and it's a lot of PCR, and eventually leads up to sequencing, and then we get all of this amazing data.
Thank you, Rachel. And our last question, again, in regards to PGX testing, what are some of the adverse reactions that can happen with the wrong type of drug?
So, for example, I'm pretty sure that some of you have heard of Stevens-Johnson syndrome, or some medications have a black box warning. So, for example, if somebody ends up getting Stevens-Johnson syndrome from some anti-seizure medications have it, they will start to break out in a rash. They can feel very ill, very feverish. Other people, if it's like an antidepressant, instead of feeling better, they may feel exponentially worse.
Thank you, Rachel. And thank you, everybody, for sending in your questions today. In summary, we learned about challenges to long-term healthcare facilities and solutions, including improving diagnostic capabilities, detecting antimicrobial resistance, and reducing treatment costs. In the future, we plan to host more informative webinars such as this. If you would like more information on this topic, we encourage you to go to our website, absolutegenomic.com. If we didn't get to your question today, we will be contacting you within the coming weeks to address any inquiries you may have on these topics. We also regularly post about infectious disease management on our LinkedIn and Facebook pages. Thank you again for your time.
Thank you, everyone. Bye-bye. Okay, I think let's turn off the recording.